And now I will hand over the particular session to our chairperson panel. Session number 6, post-lunch first session, amyloid heart disease.
I think Dr. Jaisimon need not require introduction. I'll right away start, sir.
Thank you, Dr. Mishra. Thank you very much. I know it's just postprandial state and many people would be better off outside, but we have to keep date with the program. So the task given to me is to talk about ATTR cardiac amyloidosis, role of echocardiography in early diagnosis. Why talk of ATTR amyloidosis from Indian perspective? Misconception that is a rare disease, it is not. Very limited efforts in diagnosing it. Mistaken belief that it is incurable. We have good number of drugs. Fragmented knowledge amongst different specialists. Very few dedicated expert centers. Actually, we don't have any center like National Amyloid Center, which UK has. And of course, ATTR presents with myriad presentations. So, cardiac amyloidosis essentially are three types: AL amyloidosis, or what we call as monoclonal gammopathy or light chain amyloidosis, which can be a part and parcel of multiple myeloma, but more often than not is a separate distinct entity because of plasma cell dyscrasia. The second variety is what is called as AA or secondary amyloidosis. You see in tuberculosis, rheumatoid arthritis, and also called senile amyloidosis. The type of amyloidosis we are going to talk today is transthyretin amyloidosis or ATTR. Most commonly it is wild type and occurs in elderly. However, there is a familial variety also called ATTR-M, which is familial or hereditary because of displacement and replacement of many amino acids in the transthyretin protein sequence. So there are, in addition to transthyretin protein, there are other proteins which can be abnormal, like apoprotein A1, fibrinogen, etc. So transthyretin is a protein produced by liver, and it carries thyroxine as a transporter and also retinoic acid or retinol. Once it gets destabilized, it becomes a monomer. Tetramer is actually soluble and is non-fibrillar. Once it gets converted into monomer, it becomes fibrillar and insoluble, and it gets deposited as misfolded protein in anti-parallel beta sheets in extracellular space of multiple organs. One of that organs is heart. So when you see diffuse extracellular volume expansion of the organs, including heart, the organs like heart become thick-walled. There is organ dysfunction and organ stiffness. This expansion of extracellular volume, one can pick up much better on cardiac MRI. However, echocardiogram also helps us in diagnosing ATTR amyloidosis. So this is what so far I have said, that transthyretin amyloid deposits in extracellular space will convert a normal walled ventricle, left ventricle, to this kind of thick walled left ventricle, and this is what it will look like on echo, like the case we projected today morning and we were discussing. So when the extracellular space gets studded with the monomer insoluble fibrils of transthyretin, there is change in morphology. Obviously the walls get thickened, and there is change in function. The walls get stiffer, which means that there would be diastolic dysfunction and there would be reduced exercise capacity and functional capacity in general. So this is how a classic case should present to you. Now try to recall the case which Dr. Madhu scanned for you in the morning, the walls of that patient were thick like this. Patient did have nodular thickening of the right atrial free wall, pericardial effusion here. I think I need to get the laser pointer to show you. So this is the pericardial effusion you are seeing here, nodular thickening of the right atrium, thickening of the interatrial septum, and of course left ventricle thickening. Not only that, you also see right ventricle free wall thickening. Here, right ventricle free wall thickening, and look at the interatrial septum. So this is all where amyloid material has got deposited. Now the question is, which kind of amyloid is it? Is it the light chain proteins or is it transthyretin? That echo cannot tell us. Echo can only tell us that most likely this is some kind of material deposited in extracellular space, and there is a possibility of amyloidosis. And this is something which you need to keep in mind. So amyloidosis is deposition of fibrillar insoluble proteins in extracellular matrix of the solid organs, including heart, with organ dysfunction, and it is under-recognized, underappreciated, and under-treated. The reason what the mind doesn't know, eyes don't see. The case we are presenting, we all thought, and we still think it is hypertrophic cardiomyopathy, but at least we have raised the suspicion of cardiac amyloidosis. So thick walled left ventricle, the differential diagnosis, whenever you see hypertrophic phenocopies of ventricles, that should raise the red flag for ATTR amyloidosis. Why ATTR? Because this is much more common than AL amyloidosis. So you can have concentric hypertrophy, eccentric hypertrophy, or with asymmetric septal hypertrophy. What are the conditions which should come to your mind? Am I dealing with an athlete, hypertensive heart disease, hypertrophic cardiomyopathy, infiltrative cardiomyopathy like amyloidosis or hemochromatosis or ochronosis, endocrinopathies like pheochromocytoma and acromegaly, Friedreich's ataxia, Anderson-Fabry cardiomyopathy, which is because of alpha-galactosidase deficiency. If you really want to make a correct diagnosis, you need a cardiac MRI. But in case you want to have a high degree of suspicion, echo is the initial screening method. Why we are talking again about ATTR? Because now we have number of drugs which are available to treat ATTR amyloidosis. ATTR stabilizers available at tafamidis, which has shown reduction in mortality and hospitalization. We have small interfering RNA, patisiran, and we have antisense oligonucleotide inotersen. All these three drugs are effective and more drugs are being tried. AstraZeneca is trying to bring another drug for treatment of ATTR amyloidosis, and trials are going on in this country as well. And I told you that ATTR amyloidosis is not rare. Here is actually a study, and this is from Spain. This study says that of all the patients who have heart failure with preserved ejection fraction, 13% patients have ATTR. In a recent study actually, from a single center of Spain, it shows that patients with ATTR, 2/3 present with heart failure, 7% present with AV block, the others present as left ventricular hypertrophy, and incidental finding is there in 11% of the cases. But in general, what are the diagnostic mistakes you and me make in not picking up ATTR? We commonly diagnose ATTR as hypertensive heart disease. The second common we make mistake is hypertrophic cardiomyopathy, and the case in the morning could well have been actually cardiac amyloidosis, HFpEF, aortic stenosis, ischemic heart disease, and restrictive cardiomyopathy. There are other studies which have reported a much higher incidence of ATTR in HFpEF patients. And here is another study which has shown Actually, above the age of 65 years, patients with heart failure, preserved ejection fraction, amyloidosis, ATTR of 29%. Some other people have shown that unselected 5% of all patients who we diagnose with hypertrophic cardiomyopathy have ATTR cardiomyopathy. So, transthyretin genetic screening is warranted in elderly subjects with increased left ventricle wall thickness, the kind of case we just saw. Autopsy studies show that 25% of patients older than 80 years have their myocardium infiltrated by transthyretin amyloid depositions. Okay. This is actually a study from Mayo Clinic, much sober, but probably much more reliable. And this study says that of all the HFpEF you diagnose without any antemortem suspicion, 5% have ATTR cardiomyopathy. What about India? So we believe that the heart failure patients in India are about 10 million, of which 6.5 million are HFrEF, 2.5 million are HFpEF. And organic valvular heart disease account for 1 million patients. We believe 5% of HFpEF patients have ATTR, that number will be 125,000 people. And if we believe that 0.5% of all HFrEF patients actually have ATTR, which is an underestimate, we'll have 65,000 further patients. So all in all, it is my guesstimate that there may be around 200,000 patients with HFpEF and ATTR, with heart failure and ATTR in India. We also know that the ATTR cardiomyopathy is common in aortic stenosis, including low flow, low gradient aortic stenosis. We also know that we in India have 99 million individuals above the age of 65 years, and in them the prevalence of aortic stenosis is 5%. 5% prevalence means we have 5 million individuals with aortic stenosis in India above the age of 65 years. And of those, if 12% patients have ATTR, which I'll show you from where the figure has been drawn, we at least would have 6 lakh people with ATTR cardiomyopathy and aortic stenosis. Of these people who actually have ATTR, 5% aortic stenosis will be 0.6 million, and 12% of that will become 250,000 patients. I'm sorry for that error. So, this is again a very recent study from Mayo Clinic showing how do these patients present. In their study, nearly half of the patients presented as heart failure with ejection fraction less than 50%. Now, this is an important aspect because throughout your education, you would be hearing that patients with ATTR present with HFpEF. But this 360 consecutive patients from Mayo Clinic study shows that nearly half have ejection fraction less than 50%. Commonest presentation continues to be atrial fibrillation. Whenever you see lone atrial fibrillation in an elderly person, first thing which should come to your mind is ATTR. And whenever you see pericardial effusion with heart failure, the first thing which should come to your mind is ATTR, amyloidosis, like the case we were discussing in the morning. So let me show you a case. This is a patient of heart failure I happen to see. Now, the patient has everything you ask for. You know, this patient has all thick walls. Patient also has pericardial effusion. And of course, we will talk about strain a little while later, but patient has apex which is spared. So this is amyloidosis. The question is, will the echo tell me whether it is ATTR or AL amyloidosis? And the answer is absolutely not. So the pericardial effusion and markedly reduced longitudinal function, not markedly reduced LV function, markedly reduced LV longitudinal function. ATTR should come to your mind. as in this case. But I did tell you that the patient does have nodular thickening of right atrial wall, which is a very important diagnostic sign. So when to suspect ATTR, we have gone through this whole thing. Heart failure with thick walls, HFpEF with RVH, unknown left ventricle hypertrophy, HFpEF with low blood pressure, heart failure with poor tolerance to drugs, thick wall left ventricle on echo with low QRS voltage on ECG. If there is a dichotomy between the ECG and echo with regard to left ventricle hypertrophy, amyloidosis should come at the top of your mind, most likely ATTR. So again, talking about this Mayo data, patient can present with HFpEF or heart failure with mildly reduced ejection fraction. Patient can present with unexplained left ventricle hypertrophy. Patient can present as low gradient, low flow aortic stenosis. Why bother about this? Because you do a TAVR or a SAVR, these patients don't improve. Because their problem lies in the myocardium, not in the valve. So echo phenocopies of cardiac amyloidosis we have talked about, we have discussed that, and quite often CKD and amyloidosis actually overlap, and we need to keep that thing in mind. Of late, we have seen significant number of cases coming with stroke, and we have been able to diagnose ATTR. The reason, left atrium gets significantly involved in ATTR, and this is what we are now slowly realizing, and I will show you some examples. So let us again summarize the things. In case many of you postprandial, you were sleeping, again get up and see that ATTR is to suspected in those patients who have HFpEF or heart failure with mild reduced ejection fraction, atrial fibrillation, AV block, every unexplained LVH, familial polyneuropathy, carpal tunnel syndrome. 39% of ATTR have carpal tunnel syndrome, stroke, and low flow, low gradient aortic stenosis. From where did we get the figure that 12% of aortic stenosis patients have ATTR? This is the recent meta-analysis of 21 studies, 4,243 patients. Prevalence of total amyloidosis was 15%, of which 12% were ATTR. And they were more common in low gradient, low flow aortic stenosis. So here is an example of one of our own case, 83 years male who has undergone bypass surgery, and then he had aortic stenosis. Obviously, one would think of degenerative aortic stenosis. Patient underwent TAVR, did not show much improvement, and PYP scan was positive, and we knew this is a patient who has ATTR. So aortic stenosis in the elderly, the ATTR may present in up to 15% cases of degenerative aortic stenosis. Red flag should always be systematically searched for in low flow, low gradient aortic stenosis. One of the red flags is aortic stenosis patient will markedly raise NT-proBNP. If you have a common garden, you get an NT-proBNP done in a patient aortic stenosis, you find NT-proBNP running in thousands, think of ATTR. And apical sparing on strain analysis, another red flag. You have an aortic stenosis patient and you did a strain imaging and you found that there is marked apical sparing. Like in this case of aortic stenosis, you can see actually this is aortic stenosis, this is the valve, actually this is the aortic valve which is doming. Look at this. And this patient has marked apical sparing. 10% global longitudinal strain against 60% of ejection fraction. That ratio is very important. Ejection fraction to strain ratio more than 4 is strongly suggestive of amyloidosis, more often ATTR amyloidosis. So I did tell you about the right ventricle hypertrophy and of course intraatrial hypertrophy, intraatrial septal hypertrophy. These are something which you should look for, and they strongly suggest that your patient may be having amyloidosis. And this particular individual, of course, had a light chain protein analysis and normal light chain protein analysis. We did not do actually PYP scan. Patient did not agree. But now we can say with great degree of confidence that by exclusion, this is a patient with ATTR. I did talk to you about thickening of the right atrial wall in subjects with cardiac amyloidosis with 6-sinus syndrome. So, in a patient who presents with 6-sinus syndrome requiring a pacemaker or not, you find this kind of nodular thickening, especially of the right atrium or of the left atrium. This is typical of dominant ATTR involving dominantly the atria. We did talk about apical sparing. This is actually the ejection fraction of this person, 42%. Global longitudinal strain was just 4.2. That ratio of ejection fraction to strain is 10. A ratio more than 4 is highly suggestive of amyloidosis. So this ratio of ejection fraction strain rate more than 4 has a sensitivity of 90%, specificity of 92%. Septal apico-basal index, we talked about the septal apical strain divided by basal strain more than 3 has a significant specificity, and of course the regional strain index. We did talk about that regional strain index, which is apical strain of the two segment divided by 4 segments of mid and basal strain. If more than 1 is suggestive of amyloidosis. So even if you don't do actually all the 3 views, you can see that here it is the apex which is spared. The strain at the base is 0 and at the apex is 24. This is actually a classic clear case of amyloidosis. However, the regional strain index has been looked at by the National Amyloidosis Center in UK, and they feel that the sensitivity is not that high, it's about 58%, and specificity is more like 83%. Hypertrophic cardiomyopathy as a red flag. Whenever you see patients with hypertrophic cardiomyopathy, one thought which should cross your mind is that, am I dealing with the ATTR amyloidosis? The reason, look at this graph. Above the age of 60 years, 9% patients who actually were referred for second opinion turned out to have amyloidosis. 70 years of age, 21%. 80 years of age, 26% turned out to have amyloidosis, largely ATTR amyloidosis. So I was talking to you about this particular patient in the morning. Now from nowhere you can think of, this patient actually has presented with syncope. This is an ICD lead place. You know, patient with the hypertrophic cardiomyopathy comes with syncope, you would place an ICD, you are happy. Now, this is a proven amyloidosis resembling hypertrophic cardiomyopathy. This was the case I was discussing with you. The atrial dysfunction is very gross in amyloidosis, and hence the A waves are smaller compared to E wave, much smaller. And whenever you see a restrictive pattern in a patient with heart failure, especially with thick walls, think of ATTR amyloidosis. The other variety is what is called 555 sign. All S prime, E prime, and A prime are significantly reduced in a patient who has relatively preserved ejection fraction. You should consider amyloidosis. I talk to you in a moment that the number of, we have seen about 3 patients presenting with stroke recently. This is the reason, this is one of the cases presenting with stroke. Left atrial strain. What is the left atrial strain? Look at the left atrial strain. 2%. Normal left atrial reservoir strain is 40%. 2% only. The left ventricle is just not moving, left atrium is not moving in systole or diastole. The minimum volume and maximum volume are same. So there would be a lot of sludging, and these are the individuals who, when you look at the left ventricle, ejection fraction not too bad, it has been calculated 39%, but look at the left atrium, so bad. Another example, ATTR present stroke presentation. Here, the left atrial reservoir strain is 1.5%. Left ventricle strain is reasonable. It's not too bad. It is here 14%. But look at the left atrial strain. These are These are classic examples of ATTR who present either with Sixani syndrome or with stroke, and of course also have involvement of the left or right atrium. We did talk about left atrial strain cardiac amyloidosis in the morning. Here is an example. In hypertrophic cardiomyopathy, the left atrial strain is more like 20%. Little over 20%. Here it is more like 5-6% amyloidosis. Look at the p-values. Clearly, when you see this kind of LA strain in a person with thick wall left ventricle, you have to think of amyloidosis and not have. Remember the morning case we did, the LA reservoir strain was 9%. So the transthoracic echo, what are the red flags in transthoracic echo for ATTR? Low gradient, low flow aortic stenosis, left ventricle wall thickness 12 millimeter or more, disproportionately low global longitudinal strain compared to ejection fraction, apical sparing on acoustic speckle tracking, pericardial effusion with left ventricle hypertrophy, severely depressed LA reservoir strain, and lack of mechanical atrial systole. Those of you who may be interested in reading the red flags, we did publish actually an expert consensus document this December, last December in Indian Heart Journal. So we have talked about this, but I want to emphasize only on this point. Patients who have amyloidosis, 79% have asymmetric septal hypertrophy and 25% have reverse septal curvature typical of hypertrophic obstructive cardiomyopathy. That is something which you have to remember, and do not confuse them with amyloidosis. So I will end up by showing you a quick case. This is a 56-year female, progressive dyspnea, and of course normal coronary angiogram, normal biochemistry, ECG. So intraventricular conduction defect, this is you would think is a kind of regular kind of heart failure, left atrial enlargement, more like LBB pattern, but it's intraventricular conduction defect, and some sinus bradycardia. Fragmented QRS syndrome. Fragmented QRS tell you there is something wrong with the extracellular matrix. The conduction is not occurring fast. Either there is fibrous tissue or something else. So right bundle branch block is present in a large number of patients with amyloidosis. And the reason is this extracellular matrix deposit. Anyhow, her troponin actually are NT-proBNP is 4,800 picogram, HC troponin 262 nanogram, and normal coronary angiogram. Now look at the wall thickness. Wall thickness not very much increased. If you just ignore, you do an eyeballing, you probably would ignore this wall thickening, isn't it? You might say, no, it looks all right, upper limit of normal. That is what you would think of that. But look at the typical restrictive flow pattern. Big E wave more than 120, small A wave around 50. Restrictive flow pattern. Typical 5-5-5 sign. None of the E prime, S prime, and S prime more than 5 centimeter. All fragmented. Apex, overall strain is reduced, but base is -4, apex is -12. The ratio is 12/4, 3. SAB is 3. 3 is suggestive of amyloidosis. But no apical sparing. In general, actually, when you look at it, it looks all funny. All ejection fraction 40%. Ejection fraction to strain ratio, the strain is about -8.6. 4.6, suggestive. So we have pointers, 5-5-5 sign, LVH apical sparing on strain imaging, LVH with pericardial effusion, LVH with raised troponin level, LVH with severe LA dysfunction, and of course the last thing is not there. We did actually the serum light chain analysis. In her case it was normal. Urinary LA light chain immunofixation was normal. Plasma electrophoresis per M protein was normal. If all three are normal, there is less than 1% chance of AL amyloidosis. We did a cardiac MRI. The wall thickness is not still great, but look at the early gadolinium enhancement in a circumferential manner. This is so classic of amyloidosis. But since we have ruled out light chain gammopathy, so this by default is ATTR. This is the fat biopsy, abdominal fat biopsy of the patient. This says Sections show positivity amyloid stain Congo red. Sorry, I should have actually not shown you the name. And this is suggestive of amyloidosis. So we have presented you a 56-year female with ATTR presenting as hypokinetic non-dilated cardiomyopathy, familiar history of heart failure in older brother, genotyping not done, bone pyrophosphate scan couldn't be arranged, but most likely ATTR. Let us revise what echo can tell you. When you see right wall, the relative wall thickness more than 60%, you give 3 points. This score system proposed by National Amyloid Center, UK. SAB more than 2.9, 3 points, like our patient. E2 EPRAM more than 11, 1 point. This we already have one. TAPSE, we didn't check in this case. Global strain, our patient had 8, 1, 1, 2, and 3. Score is 6 or more, sensitivity is specific 79, 78. So there is a reasonably good way of diagnosing amyloidosis based upon this scoring system. So to summarize, ladies and gentlemen, ECHO has shifted ATTR cardiac amyloidosis from a rare and untreatable disease to a relatively prevalent condition that clinicians should consider on a daily basis. Thank you very much.
Thank you, sir. Masterly talk, as always, from Dr. J.C. Mohan. Sir, I want to ask a question, sir.
Yeah.
How important ECG? It is very characteristics is described that low voltage and limblets pseudo-infraction pattern. So how much importance we should give to that to make our the differential diagnosis easier?
ECG is suggested in 50% cases. In other 50% cases, it is not suggested. You can see high voltages commensurate with left ventricle hypertrophy. You can see bundle branch blocks. You can see left atrial overload. Pseudo-infarct patterns are there in 40 to 50% cases. Atrial fibrillation 50 to 60%.
So
None of that sign is very specific.
QT prolongation is there?
Some people have QT prolongation actually. This patient I was showing you has QT prolongation.
I have a question.
Yeah.
Patient with thickened wall on echocardiography, how does the ECG help in the differential diagnosis?
So if there is a low, if the ECG does not show you left ventricle hypertrophy, you should think that maybe this is amyloidosis. There is a typical triad which is called Goldberger triad. There is a limb lead voltage are less than 5, poor R-wave progression V1 to V4, and I mean that is a pseudo-infarct pattern. And with that, if you have STT changes and the V5, V6 R waves are small, it is pretty suggestive of cardiac amyloidosis.
Suppose you have a short PR interval.
Short PR interval is not described specifically in amyloidosis.
In the differential diagnosis, it
Short PR has been described in hypertrophic cardiomyopathy.
Dannon's disease, you have Fabry's disease.
Yes, Fabry's Dannon disease actually have been described, but more often hypertrophic cardiomyopathy can have accessory pathway and short PR interval.
Dr. Subra has some question.
Light chain, type of light chain abnormality in chronic kidney disease versus amyloidosis.
The ratio doesn't change much actually, although
The
both.
ratio, nature of light chain, and which type of light chain is more marked in chronic kidney disease, the kappa light chain.
Yeah, in kidney kappa and in actually in AL amyloidosis it is the lambda chain which is more. Usually there is not much of a difference. Usually there is not much overlap. I mean you would find so much difference in the ratio going 10 times or something that you don't have any confusion. I did not show case of AL amyloidosis, but all the cases we have done, the ratio, lambda kappa ratio has been more than 10. Even urinary, but you should do both serum and urine. Sometimes serum may show borderline, urinary may show a very big ratio.
Apart from amyloidosis, have you seen any other musculoskeletal problems in amyloidosis, like spontaneous bicep tendon rupture?
So we did not discuss the other red flags because the issue was only talking about echocardiography. But the preorbital purpura, macroglossia, tendon ruptures, spinal stenosis, bicep tendon rupture. These are some of the peripheral autonomic neuropathy, postural hypotension. These are some of the things which are red flags. Chronic diarrhea, stroke, recurrent stroke, chronic diarrhea. There are many red flags actually.
Yeah, and I think this macroglossia and this periorbital PTK would be more suggestive of AL.
AL amyloidosis.
And whereas
But carpal tunnel
spinal-
syndrome is much common in ATTR.
especially bilateral.
And
especially-
especially bilateral and also spinal stenosis.
Yes, yes. No, I was just saying, like, what's in your practical experience? Like, we may not always get a low voltage ECG, but if there is this dichotomy, I mean, it's quite considerable LVH, but the amplitude doesn't really look that high. In tune with that sort of LVH. So in that case, do you think like that is indeed another strong suspicion of amyloid, and we should investigate it? I mean, it's severe LVH on echo, and there's a normal voltage in ECG.
Yes, that is one thing. The other thing which between you and me, whenever you have Scolo-Leon criteria are not fulfilled, but the Cornell criteria are fulfilled, think in terms of amyloidosis.
Any question from the audience? No. So it's a nice session. I thank my co-chairperson and the speaker. And this session is possible because of a very, academic grant from the Pfizer's. With another speakers. Oh, okay. You can invite the speakers. I don't have the program here.
So we will be having our next speaker, Dr. Oyon Kaur. The topic is a real world scenario.
Thank you both to the organizers, Rajat sir, for giving this opportunity to present the kind of heart failure work we do at R.N. Tagore Hospital. So I think the stage has already been prepared by Dr. J.C. Mohan for presenting what is actually TTR amyloid. I happen to be doing a lot of advanced heart failure and cardiac transplant, and we do a lot of sick patients, heart failure patients. So we will tell you what our kind of experience with TTR amyloid is. So roughly in the last 3 years, we've screened about 26, and we've actually picked up ATTR amyloid in about 3. And we've actually been able to treat 2, of course, not to the best. Because these diseases are actually being picked up really late. So to put in perspective, we have a 46-year-old male with persistent heart failure symptoms who was presented to our hospital for optimization, and he was definitely intolerant to standard guideline-directed medical therapy. So remember, this something is that you have to keep in mind, that patients of heart failure, despite being treated with standard guideline-directed medical therapy, tends to be symptomatic and keeps coming back for repeated readmissions. These are patients where you really know things are not working. Typically, as we know, heart failure with preserved ejection fraction happens to be a subset which is always difficult to treat, very limited therapeutic options, and to that you would add ATTR, and the reason why you need to pick up ATTR is possibly because there are novel treatment strategies to treat it with. So this patient was a 63-year-old male, lives with his wife, his son was away in Japan, and he did not have any standard cardiac comorbidities. So no hypertension, no diabetes, no hypothyroid, no dyslipidemia. He was having shortness of breath for almost a year now. By the time he presented to us, he had a 3-pillow orthopnea since the last few months with frequent presyncope. At the time of admission, he is NYHA class 4 with a 6-minute walk distance of less than 50 meters. 2 hospital admissions in the last 2 months. He's been initiated on guideline-directed medical therapy with only worsening. Typical worsening means he does not tolerate beta blockers in particular, And on initiating ARB or ARNI, I mean, he generally his creatinine shoots up, potassiums are not tolerated. So the only thing he really has been tolerating has been a low dose of torsemide with some amount of aldactone. So clinical examination was significant for signs of biventricular congestive heart failure. So these are the patient's echoes. I would apologize for the clips, but yes. So as you can see, so typically we call this, these are small cavities, thick ventricles. They are hypokinetic to begin with. And this patient was very sick. And as you can see, there's a chink of pericardial effusion right below. I will draw from the paper, position paper that Dr. J.C. Mohan has already spoken about. So typically these patients present with an LV thickness greater than 11 millimeters, low GLSs. If they have aortic stenosis, cardiac conduction abnormalities, you should red flag these patients as ATTR amyloids. Thick-walled, non-dilated hypokinetic ventricles. So after I'd seen this echo, I decided to go back and see through the patient's file. So it was a referral at this moment. And of course, so you can see the echo again. So you can see that the ventricle is definitely dysfunctional to begin with. There is some amount of pericardial effusion just below. And this patient was barely able to lie down for an echo. So this is what the echo looks like. So as Sir was already talking about, a lot of these patients actually present with right bundle branch blocks. But what is very stark, I mean really something that should be a pointer in your eye is the low voltage complexes on this echo. For the amount of hypertrophy that patient having these kind of low voltages is what we typically call as the ECG echo mismatch. So, and then you talk about the restrictive filling patterns. You can see that the EA ratios are definitely altered, and that is why these patients have severe. So this is the 555 sign that Dr. J.C. Mohan has already told you about. The S prime, E prime, and the late diastolic A primes are all below 5, all suggestive of a myocardium which is not working. So it is talking about that this myocardium is definitely not healthy. And so this is something that we've seen. So as you can see, so as I was saying, it's not so much about the LV, it is about the longitudinal work of this myocardium, which is actually abnormal. So coming to lab parameters of this patient. So this patient had a pro-BNP of 14,781, a creatinine which was already 1.75. Those were the days of COVID. So this was in the year 2019. We were in peak COVID. And so his EGFR was 42.78. A lot of people said that, oh, this patient definitely has COVID. And at that point of time, we basically managed to do a serum protein electrophoresis, which was negative for monoclonal spikes at that moment. However, at that point, I was rather not aware that we also had to do a urine free light chain as well as a urine protein electrophoresis to put him on the Pfizer rare disease program for getting tafamidis. At that point, so at this point, were already planning for a cardiac transplant. We decided to take him up for a right heart cath. And as you can see, the pressures wise, he has definitely significant pH with a mean PAP of 50. PC wedges were in 35. Transpulmonary gradients preserved at 15. His RV EDPs were 33. And what you can see is the PAPI is 1.9, which tells you that the RV is still fairly preserved with an RA to PC wedge of about 0.6. Further delineation, if you look at echo wise, so what you typically see is on the T1 scout images that you would see that you would not be able to null the myocardium like you would generally want. That is basically because the myocardium and the blood pool typically has similar T1 times. And you would see that there is a lot of late GAT contrast in a non-vascular territory, which means that this is typically not like the ones which we see after infarction. So it is not in an LAD territory or an LCX or an RCA territory. So this is typically in non-vascular territories. So we decided, since we were not, so we really needed a diagnosis as to what was happening, because infiltrative cardiomyopathies, listing them for cardiac transplant comes with its own share of problems, because you really don't know what disease you are looking after. So let's say it's a rare systemic disease which generally involves other organs, it needs to be treated otherwise, and they may not always be the best candidates for transplant. So the endomyocardial biopsy shows you on polarized light. So the same thing is a very classical apple-green birefringence of amyloid proteins. And this was kind of a breakthrough at that point of time, which is where we decided to get in touch with a few more experts. We wrote a few mails to Singapore, we had some talks, and then we figured out by then that this was the year 2019, peak COVID, not too many people to ask for help. So we decided to go ahead and do a pyrophosphate scan, which was available at that point of time. And this really shows you that this was a Perugini grade 3 pyrophosphate scan, where you can see that the heart really lights up in the middle of the mediastinum. And what is very important when you ask for a pyrophosphate scan is that make sure that it is done on a SPECT, because your blood pool imaging has to be cleared of the scans before you really scan the myocardium. It is very, very important. So this is how the Perugini scale is done. So the Perugini scale is all about a visual scale. It looks basically at whether it basically compares between the uptake between your heart as well as your general mediastinum. So if the heart uptake is more than that of the mediastinal uptake, we generally say this is grade 3. Anything in excess of grade 2 is ideally somebody who can be worked up for a ATTR-CM, provided of course that his light chain gammopathies have been ruled out, which means that you need to have a serum protein electrophoresis, a free light chain, as well as urine protein electrophoresis negative for monoclonal gammopathy. So this is something again that sir has already spoken about. We are talking about the apical sparing and the restrictive filling patterns, which is very common in this group of patients. So this brings us to the ESC myocardial working group position paper, which actually put all of this in a lot of perspective and put us and gave us basically a head through as to how to work up ATTR-CMs. And so we've been basically looking at patients with, typically you would start off with the ECG echo mismatch and then followed by a diagnostic algorithm, which we are already talking about. And what I think sir probably did not allude to is that he also actually set across what is known as the Indian expert consensus, and this is actually the Indian guideline of looking at ATTR-CM. So moment you have LV thickness more than 11 millimeters, the first thing to order is going to be the pyrophosphate scan. Reasons being, it is actually much cheaper than a cardiac MRI, far cheaper, and it's far easier to interpret, and it basically gives you an idea whether this patient is actually going to be ATTR or not. If your pyrophosphate scan is Perugini grade 2 or more, that is where you look for, you need to rule out monoclonal gammopathies. So do all the 3 tests for monoclonal gammopathies. And then once that is proven, these patients ideally can be sent for genetic studies. And that is predominantly not to change line of treatment. The line of treatment purely is going to be dependent on your pyrophosphate scan and your monoclonal gammopathy screening. So depending on that, these patients can now be put into tafamidis. Of course, that is something that will come to later. So why so much hue and cry? I think we know because now we can treat this disease. This was something that we were not really so aware of. So this would be my last slide. So take home and quick tips would be the ECG echo mismatch, history of bilateral carpal tunnel syndrome, intolerance to standard guideline directed heart failure therapy. Always think that this could be ATTR. Autonomic neuropathies, to invoke a diagnosis, you have to rule out plasma dyscrasias. And of course, a technetium pyrophosphate scan is very much available and it's very cost effective. Thank you so much.